Welcome everyone to the National Brain Tumor Society's webinar titled What Brain Tumor Patients Should Know About Radiation Therapy. Today's webinar will provide an overview of radiation therapy that may be involved in the brain tumor experience, including the types of radiation currently available for brain tumor patients, as well as information on the latest research and advancements in radiation treatment. There will be a question and answer session at the end of this webinar. If you have questions, please use the chat feature located at the bottom of the Zoom screen. As a reminder, this webinar is intended for general information, and questions about specific cases cannot be answered here and should be brought up with your medical team. We are pleased to have Dr. Eric Sulman, co-director of the Brain Tumor Center at Promet Cancer Center and the Vice Chair for Research in the Department of Radiation Oncology at NYU Langone Health, joining us to present. Dr. Sulman is also a member of the Defeat GBM Research Collaborative and has been nationally recognized for his work in brain tumor research. Welcome, Dr. Sulman.
Okay, well, thanks to the MBTS for a chance to speak to all of you, and thank you for tuning in. Hopefully this will be informative and clarify some questions you might have about radiation. I'm going to cover several things today. So I'm going to talk about the basics of radiation. I often find that my patients are unfamiliar with exactly what radiation is and how it's working. And so I will, if you'll forgive me, have you dig back to some of that high school physics, but nothing more than that. Then I'll talk about how we use radiation to treat cancer, and then what types of radiation we have available for our treatments, and then how our technological advancements in radiation oncology making radiation safer and more effective. And along the way, I'm going to touch on clinical trials that have either recently been completed or are currently accruing patients right now. And then at the end, as you heard, you'll have some opportunity to ask questions. Radiation can be a scary thing to think about. And though many of you who are watching now are familiar with radiation treatment, it still sounds like something out of the atomic blasts. And indeed, if you talk to people from the previous generation who received radiation pre-1980s era, radiation was very toxic and burned people's skin. So for example, a lot of the toxicity we are concerned about when it comes to neurocognitive effects of radiation, a lot of that has to do with some of the older techniques. Nowadays, radiation oncologists publish a lot of papers in the scientific community looking at the long-term effects of radiation. And this is somewhat unusual compared to other oncologists. And so as a result, we have a lot of data to tell you what will happen a month, 2 months, 6 months, 2 years, 3 years after treatment. And that too can sound very scary. So let's step back and ask, what is radiation? And most of the radiation that we use to treat patients is actually called ionizing radiation. And what that means that radiation, and think of radiation as energy from light waves. So what you're looking at here is the so-called electromagnetic spectrum. And on the left side of the screen, you see the kind of frequencies we find in radio waves and shortwave radios. And on the right side of the screen, you see things like X-rays and gamma rays. And it's really those things on the right side of the screen that we're focused on in treating patients. And what these waves of radiation do is they remove electrons from atoms, electrons that are buzzing around the atoms. They remove them, and the electrons fly out of the atom at a very, very high speed and bombard other atoms. And the net effect of this is they eventually bump into water molecules, H2O, that's sitting around the DNA, the genetic material of the cell. And when they bump into those, they create a very unstable free radical molecule that has the effect of destroying the DNA, of actually cutting it. And so that is the primary effect of ionizing radiation. Now what happens is that the DNA, when it's broken, sometimes has trouble reconnecting in the right way. And part of the reason it has this trouble is because cancer cells have often adapted to turn off the DNA repair machinery that normally exists in all of our cells. And the reason they do that is because it's easier to divide more rapidly when you're not stopping to fix things. So they don't repair things properly. Normal cells of the body do repair things properly. So what happens is our strange connections of the DNA, these so-called aberrations, which if you can see my arrow, this funny looking oblong loop structure in the middle of the screen, That structure cannot be divided. So when the cell goes to divide itself and make another cancer cell, it has to self-destruct because it can't divide that chromosome. And so that is how radiation works. But the reason that's important, and important in our understanding of when you go to the doctor after you've had radiation, is that the cancer cell has to divide first before it self-destructs. So if the cell has been treated with radiation, it may not look different until it goes to divide. And not all cells in a tumor are dividing at the same time. Some will not divide for many months. And so, as you may have been told by your radiation oncologist, the tumor may look the same after radiation because the cells have not yet tried to divide and therefore self-destruct. And indeed, if we look during radiation, we very often don't see any differences in the tumor, which is why it's unusual to get frequent scans of the brain during radiation treatment. So radiation oncology has gone through a large number of technological advances. Radiation oncologists seem to like technology probably more than almost any other discipline of medicine. So on the one hand, we have what are the goals of radiotherapy? And that are, of course, to prevent the tumor from growing and regrowing and to reduce its size. At the same time, we want to reduce the toxicity of the treatment and reduce the long-term effects of the treatment. The first uses of radiation in its initial discovery were actually for treating people. And they go back to the early 1900s, from the days when Marie Curie first found radioactivity. And that is what we call brachytherapy, where radiation was actually implanted inside tumors. In the 1950s, there was a chemical developed, a radioactive substance called cobalt-60, and this allowed for effective radiation treatment without putting something inside or very close to the tumor. Teletherapy just means from a long way away, which is the kind of therapy you're used to today. Radiosurgery, which I'll talk about later, was developed in the 1960s. And believe it or not, proton therapy, which you may have heard about as something very new, is actually also goes back to the 1960s. From then, we evolved to plan more from a three-dimensional perspective as opposed to just planning our radiation looking at X-rays. And so we used CAT scans and today MRI. And then how the radiation was delivered, I'll talk about in the next several slides with all these four-letter acronyms that all began in the 2000s. And all of these things have had a very significant effect on reducing toxicity and improving our accuracy of treatment. So I said the goal of radiation is to improve the control of tumors and at the same time reduce complications or side effects to normal tissues in the brain. And this gap, this difference between maximum tumor control and minimum toxicity is called the therapeutic index. And so what we're always trying to do is increase the therapeutic index. And so all of our technologies focus on that. So the first thing I like to remind everyone is radiation has been shown since the late 1970s to be the most effective therapy for brain tumors. There were a bunch of trials, clinical trials, done back by a group called the Brain Tumor Study Group in the late 1970s, all of which showed dramatic improvements in patient outcome with the addition of radiation after the tumor was resected surgically. And at that time, the chemotherapies weren't very effective, so the addition of chemotherapy to radiation wasn't that helpful. So what do we treat? Each of you on this webinar may come from a different disease background, but we actually treat a number of different types of tumors in the brain. There are benign tumors, which include many of the meningiomas. These are tumors of the lining of the brain and spinal cord. Acoustic neuromas, which are often called vestibular schwannomas. These are tumors of the nerve that's related to hearing and balance. And then there are, of course, malignant tumors, and these are often called gliomas. And there are different types of gliomas. There are gliomas of the lining of the fluid areas inside the brain. And then there are gliomas that exist within the brain tissue itself. A very common area of treatment are actually tumors from other parts of the body that go into the brain, say tumors from breast cancer or lung cancer or melanoma that have metastasized to the brain. And in fact, these represent hundreds of thousands of patients a year. And just as tumors can go to the brain, they can also go to the spinal cord, typically to the bones of the spinal cord, but because of the close proximity to the spinal cord itself, it requires very specialized treatments. And of course, we treat many pediatric patients because brain tumors are the most common solid tumor in pediatric patients. So here are some of the advances that are currently being studied in radiation oncology and in brain tumor treatment. Normally, we identify what to treat and what to avoid using magnetic resonance imaging, the so-called MRI, which I suspect most of you are familiar with. But there are new technologies. There are things called metabolic scans. And what metabolic scans means are they use something that identifies which cells are actively using nutrients. So in this particular image, they're looking at something that's actively using tyrosine or methionine. And these are building blocks used for the cells so that they can make the molecules they need to grow and divide. And what you see in this image is that the surgeon has removed an area of the brain, and that's in this bottom right of this image, that dark area. But when they did that, they inadvertently left behind an area that is very metabolically active, that red dot on the right side image. And therefore, without this kind of metabolic imaging, it wouldn't be possible to know where to treat with radiation. And so this is really the wave of the future to allow us to treat more effectively areas of activity. Now, sometimes we want to avoid areas where we know things are quite active. And so what we would do is draw out the structures that we want to avoid, things like the nerves of the eyes, the lenses of the eyes, the brain stem. But sometimes there are areas of the brain we want to avoid which don't have a visual appearance on a typical MRI. And so we can do something called functional MRI. And in functional MRI, the person is doing some kind of activity during the MRI which identifies which part of the brain is affected by that activity. And then we can identify that area and avoid it with the radiation. And you can see here the white areas that are circled in red on the MRI, how one of those areas is in close proximity to the area being treated with the radiation. The radiated area is outlined with the wavy lines on the right side of the right-hand image. So I mentioned that early on in the development of radiation technologies, we used to burn the skin quite a bit, and this was back in the 1950s and 60s and even 1970s. With the development of modern radiation therapy delivery devices, we now avoid delivering much radiation to the skin. So this is a graph that radiation oncologists are all familiar with, but I'll walk you through it. What you see is how much energy is being deposited in tissue based on the depth of penetration. And if you look where the 1 centimeter mark is, you can see that as the energy level increases in the radiation beam, so the red line is the highest energy level, the amount of relative radiation dose is much lower at 1 centimeter. So what ends up happening is the radiation is deposited deep inside the tissue, deep inside the brain, and not on the surface of the skin. In this way, we avoid significant burning of the skin. Now, of course, this doesn't prevent hair loss, which often happens because even low amounts of radiation will cause hair loss. And it can often still occur to get that dry, itchy scalp from radiation, but not the kind of burning that was seen 40 years ago. So again, as you all know, radiation is delivered a little bit at a time. We call that fractionated radiation because we give a fraction of the total dose. Typically, each day is the same dose, and we typically deliver it over a fixed number of days. The reason we do that is that it was shown long ago that if we give enough radiation to kill some of the cancer cells on that day, there's not so much radiation that the normal tissues in the brain can't recover. If we give too much radiation in a single day, even the normal tissues will be damaged. But if we give too little, not enough cancer cells will be damaged. So we pick a point where we give enough radiation to kill the cancer cells, but not too much to destroy or damage the normal tissue. After 30 treatments, it is our hope that we've destroyed all the cancer cells without causing significant damage to the tumors, to the normal tissue. So one kind of radiation I'd like to introduce, which some of you may be familiar with, is whole brain radiation. And this is typically used either when there are many tumors from other types of cancers that have gone to the brain metastases, or for a particular kind of cancer called small cell lung cancer, where it's used to prevent tumors from going to the brain. And in this treatment, what you see here in the sort of a profile shot, and of course you're seeing only the bones because this is an X-ray, is that we're treating the whole brain, but those white horizontal bars are blocking the face. And so it's just important to note here that we don't treat the face, the mouth, the throat, the front of the eyes with this treatment. And it typically goes for 2 to 3 weeks. Now, this is a kind of radiation where we're treating with three-dimensional treatment planning. So the image I just showed you was just an X-ray, but now what we're using is a CAT scan and an MRI to design the treatment. And what you see here is that now those shaded areas represent the areas we intend to treat, and the thick lines that surround them are the radiation doses spreading out from the area we're trying to treat. We are now shaping those radiation lines around the areas, the targets of our treatment, and that makes it conformal. What are the areas that we treat with three-dimensional therapy? So this, I'm telling you the terms that radiation oncologists like to use, so that if you ever hear them use it, you'll now know what they're talking about. The area where the tumor is visible, or where the tumor was removed, we call the gross tumor volume, the GTV. But then we treat an area several centimeters outside of that, surrounding it, where we think there might be tumor cells that have infiltrated, have migrated into the normal brain, and we call that the clinical target volume, the CTV. We also know that every day, no matter how hard you try, every patient will move ever so slightly, even with the mask that's used to hold the head in place. And so we take into account that margin of error, that little bit of movement, and we call that the planning target volume. And so that is actually the area that we're trying to encompass. We want to get all of the PTV in our treatment. So today we don't use three-dimensional conformal radiation alone. We use an advanced form of it called intensity modulated radiotherapy, or IMRT. And though I am almost certain all of you have heard about IMRT, I suspect most have not actually had it explained to them what it means. It is still three-dimensional therapy. We still use an MRI and a CAT scan to shape the treatment. But what we use are very thin beams of radiation that have different intensities. And by summing these little beams up and having them come from many different directions, we actually can reduce dose in adjacent areas to the treatment volume dramatically. And so what I'd like to do is draw your attention to the right-hand CAT scan image, the top right box. What you see is a bunch of black outlines, which represent the brain stem right in the middle of the scan. And you can see a white line surrounding the target volume. And that white line, you can see how it's bent right over the top of the brain stem. That is not achievable with conventional three-dimensional therapy. That's only achievable with IMRT. And that was a way to avoid giving too much radiation to that brainstem. So IMRT today is taken even one step further, and it's called volumetric modulated arc therapy, or VMAT. And indeed, today, many treatments are being delivered with VMAT. And though VMAT uses tiny little beams of radiation similar to IMRT, it delivers them in a continuous movement of the radiation treatment machine, here shown as a sort of time-lapse image, where the treatment machine moves in an arc over the patient's head and delivers the radiation while adjusting the beam size and intensity as it moves. And so there are indeed some advantages to this treatment. So the top two boxes show standard IMRT, and the bottom two boxes show VMAT. And what you can see where I put the arrow is that those radiation lines on the top images are going to the areas of the brain that are not an intended target of treatment. But if you look at the VMAT, you can see that those lines are not dipping down into the lower portions of the brain. And so we were able to protect more of the normal brain using the VMAT approach than standard IMRT. We talk a lot about the toxicities of radiation and what are the things we want to protect. One of those things is an area of the brain called the hippocampus. And this comes from a Greek word for seahorse. And I'm led to believe that that somehow looks like a seahorse, but I find that sometimes hard to believe. But the hippocampus is a very important structure in learning and memory. So when we deliver whole brain radiation, we've been investigating what can happen if we limit the radiation dose to the hippocampus. So what you see in these three images at the top of the screen are the radiation doses going to the hippocampus. Now this is like an inverted image from the ones I've shown you before. The doses to the hippocampus get less and less as you go into those rings. And the dose to the rest of the brain is what's actually higher. And so by reducing dose to those areas of the hippocampus, we think we can preserve memory and learning better than by treating them uniformly with whole brain radiation. Similarly, we can avoid the hippocampus when we treat with targeted radiation, not the whole brain like we do for most of the gliomas. So how much radiation do we deliver? The unit of radiation is called a gray, and this reflects an energy that's absorbed in the tissue. And so GY means gray. So for glioblastoma, we typically deliver 60 gray in 30 treatments or 30 fractions, and it's typically given with the chemotherapy drug temozolomide. For grade 3 tumors, which are called anaplastic gliomas, we may deliver 60 gray, or some places deliver a slightly lower dose of 57 gray, but typically in 30 treatments. And as you get to the lower grade gliomas, like the grade 2 gliomas, then we might deliver 50.4 to 54 gray, so somewhere in that range, and that would be over 28 to 30 fractions. Now, of course, we're delivering only 5 fractions a week, so 30 fractions takes 6 weeks. Other tumors like meningioma, when they're in the benign type, which is the grade 1, we may only deliver 45 gray, and the more malignant types, we might deliver 60 gray, the same as glioblastoma. Whole brain radiation for brain metastases is typically in the range of 30 to 37.5 gray over 10 to 15 fractions, or 2 to 3 weeks. And typically no chemotherapy is given with whole brain radiation. And then there's a very special kind of radiation called stereotactic radiosurgery, which is not surgery, but delivers so much radiation that it acts like the scalpel of a surgeon in the way it destroys the tumor. And that means it's given in one day, one time, and the doses are quite high. So instead of just 2 gray in that one fraction, which is what we're giving in all the other treatments, this one is 12 to 24 gray in the one fraction. So I mentioned this idea of reducing dose to the hippocampus, and I'll just point out that there is a clinical trial whose results we should learn about very shortly, likely within the next month, which compared the use of standard whole brain radiation to HA whole brain radiation, which is hippocampal avoidance whole brain radiation. And so we're interested to see if this benefited people in this randomized trial, which is, of course, the best way to really ask this question. Now, in this trial, all patients were given a separate drug called memantine. Now, this isn't a drug that's a chemotherapy drug. This is actually a drug that's used to preserve memory, and I'll show you that in just a moment. So memantine is a drug actually given to patients that have Alzheimer's dementia. And it turns out it protects normal neurons. And because it was developed for Alzheimer's, it also was developed to get into the brain, which makes it a good drug to study for other things where you want to have the drug in the brain. And so this was a clinical trial that was published back in 2013. And what it showed is that cognitive function was improved over the long term by giving patients this drug, memantine, when giving whole brain radiation. Now, one of the questions we're asking now is it beneficial to give this drug when giving partial brain radiation, for example, when we treat gliomas? And so that's an unknown at this point, but it's something that's being studied. I mentioned stereotactic radiosurgery, that focused, intense radiation given in a single day. This is delivered as an outpatient, so it's not like typical surgery. And of course, nothing is used to get into the brain. There's no cutting open of the brain. It's used primarily for brain metastases, as well as some of the benign tumors I mentioned earlier, the acoustic neuromas, the meningiomas. Sometimes it's used for recurrence of gliomas. When the tumor grows back and it's a small nodule, sometimes we use stereotactic radiosurgery there. And there's actually a host of non-oncologic, non-cancer reasons to use stereotactic radiosurgery. For example, blood vessel malformations in the brain are sometimes treated this way. The treatment usually requires attaching a metal frame to the skin, to the scalp, in order to have very, very precise targeting. Since you're delivering all the radiation in one day, you can't miss, because you don't have another 29 days to correct the mistake. So stereotactic radiosurgery is not a new technique. It originally developed back in 1949 by a Swedish neurosurgeon named Lars Leksell. It then was used in the 1960s, actually using proton radiation. And then in the 1970s, the use of what is one of the most common machines to do stereotactic radiosurgery, the Gamma Knife. Later in the 1980s, conventional radiation machines, which we call linear accelerators, were adapted to use for stereotactic radiosurgery. And this just shows you some of the different machines over the years. You can guess that these photographs are old looking at the picture, but that is indeed Lars Leksell leaning over the patient back in the 1960s. These are some of the modern devices we use. There's one called a CyberKnife, which is a robotic arm actually developed from the automotive industry. And then there is various other approaches for delivering stereotactic radiosurgery using modern standard radiation delivery machines. This is a schematic of the Gamma Knife, the most commonly used machine for stereotactic radiosurgery. And what you can see here is the patient is moved around so that the 192 radiation beams around the patient's head can target precisely the tumor. And so this is a very precise technique. I'll just mention briefly that we can also treat tumors of the spine. I mentioned that that's an important area in radiation oncology. And of course, the spinal cord is just an extension of the brain. We can treat the spine the old way, which is over 2 weeks, just like we kind of treat the whole brain. We can treat a whole section of the spine. But you can see on the image on the right that when we do that, we give radiation to the abdomen, the gastrointestinal tract, even the skin of the stomach. We can also, though, do very precise radiation, shown on the left, where we're giving radiation just to the bone that has the tumor. And you can see, because we used IMRT, we bend the radiation around that red circle at the bottom here, which is the spinal cord. And then we're able to avoid giving toxic doses to the spinal cord. So another more recent advance in radiation treatment is something called image-guided radiation therapy, or IGRT. So IGRT is actually a concept that has always existed in radiation oncology, and that is we do some kind of an image of the patient to make sure that the patient is in the right position every day, so we're not missing the intended target. But nowadays, we have all kinds of fancy machines to help us get these images very, very quickly and in real time, so that there's no waiting around on the treatment table for the images to be taken. And by doing this sophisticated IGRT, we can reduce that area of motion uncertainty that I talked about earlier, called the PTV. And even reducing that by 2 millimeters all the way around the tumor is a dramatic reduction in the volume of normal brain tissue that we have to treat. And so this is something that most centers have moved to in recent years. This is an example of IGRT. And what you see in this image is a radiation treatment machine. And you see the patient in blue lying down. You see these orange beams coming up from the floor. These are X-ray beams that hit screens in the ceiling. And so the patient is exactly in the position. Of course, this is not a brain tumor patient, but we use this for brain tumor patients all the time. And we can verify that the patient is in the right position. This only takes an instant to capture. And then if everything looks good, we just start the treatment right away. And we can do this every single day. And we can even do it multiple times during the treatment if there's any concern that a cough or a slight movement might have resulted in a need to check position. Another way to do IGRT is by actually taking a CAT scan while the patient is lying down in the on the treatment table. So this is an example of something called CAT scan on rails, or CT on rails. And what you see in the top left image is the treatment table that you lay upon to get radiation. And the whole table rotates 180 degrees on the floor. And then that circular thing on the left is the CT scanner. It slides on rails, which you can see as those stainless steel strips in the bottom of the floor in that room, and actually takes a CAT scan. And then that CAT scan is aligned to the original radiation treatment that we plan to deliver, and any adjustments are made. Most modern radiation treatment machines in the last 3 to 5 years also have something called a cone beam CAT scan. And this means we can actually use the radiation treatment machine itself to rotate around. And so some of you may have experienced this. The whole machine rotates all the way around your head and generates a CAT scan of your head just using the machinery already built into the radiation treatment machine. And then again, this is aligned to what we think it should be the proper alignment, and any adjustments are made in real time, and then we can treat. So I wanted to also talk about proton radiation. So proton therapy delivers all the energy to the tumor and as it enters the patient, but after it gets past the tumor, there's no radiation delivered. So take a look at the two images below on the screen. The yellow area is the area where the most radiation is delivered, and the background area of sort of light blue is where there's no radiation. In the X-ray beam, the tumor, which is represented by that square in the middle, you can sort of see the word tumor, you can see that actually a higher dose of radiation is up here by the skin. Now we're sparing the skin, so it's not right on the skin, but it's just below it. And then it passes through the tumor and it continues out of the patient as this lower energy, this purplish energy to the right. Now, if you look at the proton beam, the radiation enters. Now, there is more radiation to the skin, but once it delivers all the radiation to the tumor, which is that bright yellow area, there's no radiation afterwards. This is sort of a graph to explain that. And it really, if you just look at the graph on the right, you can see that as you enter with the left side of that graph, the point 0 being the surface of the patient, and the right side going deeper, you can see that X-rays in the brown deliver the entrance dose close to the skin, whereas most of the dose is delivered just to the tumor with proton therapy, and there is no exit dose. Proton therapy has actually been around a very long time. Even so, there aren't many centers that have it. It actually goes back to the 1950s at Harvard, where they used a physics device called a cyclotron, and they managed to get a proton beam out of it to use to treat patients. So the first patient was treated in 1961, and the last patient using this physics-based treatment machine was in 2002, and by then they had treated almost 10,000 patients. Since that time, they built a facility only for treating patients. It's not used by the physics department, as have many other centers in the country. Indeed, there are over 40 proton centers available worldwide and more than 20 centers in the United States. And there have been many, many research papers on the use of proton therapy. The proton machines are costly to construct. So this image on the right shows you what is called the gantry, which is actually what you need to treat a patient. If you look at the image on the left, this is a drawing of that same gantry. If you look in the middle of the circle on the front, there's the treatment table. You can see how small that table is. That's actually where the patient is. The building is built around this gigantic structure, and you can see this workman on the bottom left of the right-hand image, just how small he is in comparison to the gantry. The gantries are 35 feet in diameter, and they weigh as much as a commercial jet airliner. So these are very, very expensive to build and install, and you need a very sophisticated building to house them. So there is a benefit to proton therapy. It can improve tumor control. It can increase the amount of dose you're able to deliver because you don't deliver as much to normal tissue. And it can potentially reduce the toxicities of radiation by delivering lower doses or no radiation to uninvolved tissue. And that last one is important for tumors that, particularly the benign tumors, where 30 years after treatment, there is a risk of developing a new cancer just from the effects of radiation. So by not delivering radiation to normal tissue, we reduce that risk substantially. So here's a comparison of conventional IMRT to proton therapy. And what you see here is that the protons, actually, I apologize, the labels are reversed. The top is the protons, the bottom is the IMRT. And what you see in the bottom, which is the IMRT, is that there's a lot more radiation going to the normal brain, that sort of purplish and sky blue spread all around the brain. So if you look just at the two left-hand images, you can appreciate the difference in radiation dose between these, the upper, which is in fact the protons, and the lower, which is the IMRT. So there's a clinical trial that we're waiting for the results on that asks the question, if you randomly assign patients with newly diagnosed glioblastoma to get standard IMRT radiation versus intensity modulated proton therapy, does cognition, memory and learning, is it less effective with the protons than with the standard radiation? So that trial is no longer accruing patients, but we're now waiting for the results, which will hopefully come out in the next few months. Similarly, for lower grade gliomas, these are the grade 2 and grade 3 gliomas that are not glioblastoma, a similar trial is underway right now to ask the same question with the same approach, using standard radiation versus proton radiation. And so this trial just began earlier this year, and so it'll be some time before we have those results. Some types of radiation are necessary for certain types of cancers like medulloblastoma and ependymoma. These tumors are particularly common in children. And in those tumors, we have to treat the entire spine and brain. And treating the spine with conventional radiation often results in radiation going to the abdomen and to the kidneys. And so it's very toxic, and also people don't feel very well from it. They get a lot of nausea and diarrhea from it. Using proton therapy, it's possible just to treat the spinal cord and the brain with no radiation going to the rest of the body. And so this has become the standard for pediatric patients with these types of tumors. I mentioned the intensity modulated proton therapy. So this is the latest generation of proton treatment. And what it does is a little different than the intensity modulated radiation therapy. For those of you that remember the dot matrix printers of old, where we used to print with that high-pitched sound, and it would make the little dots to form the letters and graphics. Well, that's indeed what we do with intensity modulated proton therapy. We deliver little dots of radiation over the tumor to really, really, really shape it and make it conformal. And so this is really the most advanced type of proton therapy. So intensity modulated proton therapy does even better than standard proton therapy. And what you see is, if you look at the bottom right image, it's a little hard to appreciate, but we're giving even lower radiation dose to the uninvolved brain with the IMPT over the standard proton, and certainly lower than the X-ray based radiation treatments. But with all that said, why don't we use protons for every brain tumor? And the truth is that the evidence is not yet there for treating some types of brain tumors. So there are some types of tumors like chordomas and chondrosarcomas, which occur at the skull base, which there's really very good evidence for using protons. And then for some of the meningiomas and other benign tumors, there's some evidence, but it gets weaker as we go through glioblastoma and the truly benign cases and the brain metastases. So we just don't know in those cases yet if it should be the standard treatment. Now, regardless of whether you're using protons or standard X-ray radiation, one question we ask is it better to give more radiation? And with all these new techniques, it is indeed possible to do so. And so this is just showing you what biologically is the reason to do that. We know now that inside the tumor, there are cells responsible for regrowing the tumor after radiation. And if we give more dose, we might be able to destroy those cells as well. So there's a clinical trial going on right now called NRG-BN001, which is asking the question that if we go to that higher dose, 75 gray, will we do better than if we went to 60 gray? And there's two groups in that trial. One group is treated to 75 gray using protons, and the other is treated to 75 gray using IMRT. So the results of this trial will answer a lot of questions, and it'll hopefully finish accruing patients in the next year. What about combining radiation with other therapies? Many of you know about combining it with chemotherapy, but there's been a lot of talk about combining it with immunological therapy, the so-called immuno-oncology. And then there's also a type of treatment called tumor treating fields, which I'll talk about, and how that might be combined with conventional ionizing radiation. So it's now standard for glioblastoma to treat concurrently at the same time radiation and the drug temozolomide. And temozolomide is also used for many other types of gliomas. And the reason it works is because temozolomide radiosensitizes. It makes radiation work better, be more effective. And this was the clinical trial that established that as the standard treatment for glioblastoma, originally in 2005, and this is the long-term follow-up in 2009. And when it comes to immunotherapy, which has been a very hot topic in other disease sites, like in this case, lung tumors, there's a concept called the abscopal effect. And this is the idea that if you treat one part of one tumor in a patient that has multiple tumors, if you treat one tumor with radiation, the immune system will then respond to that treated tumor. And once it does, it will also seek out the untreated tumor and destroy that as well. And so this is an example of the abscopal effect of a patient that had a tumor in the lung and a tumor in the bone of the arm, and both tumors went away, even so only one tumor was treated. So when it comes to the brain, there are now a number of trials looking at combining radiation with what are called checkpoint inhibitors. These are drugs that make the immune system more activated. And so these trials are all underway, and we're waiting to see what the results are, and has a potential for some significant improvement, we hope. So there's another kind of radiation called non-ionizing radiation. And non-ionizing radiation is radiation that doesn't cause those electrons to fly out of the atoms and bombard water. And a good example of non-ionizing radiation are the microwaves of your microwave oven, or what's used for radio and television, but also something called tumor treating fields. So tumor treating fields were reported last year in a clinical trial compared to the standard treatment that we do for glioblastoma after radiation, which is to give temozolomide by itself for 6 to 12 months. And so they added to that tumor treating fields, and they showed that there was a significant benefit to temozolomide in tumor treating fields. I'm seeing some drawing on the screen, so I apologize. I can't read the chat session while I'm talking, but I will look at it as soon as I'm done. So this is an example of the device used. This is a slightly older version than what you would get today for tumor treating fields. This is goes by the brand name Optune, and it has the effect of preventing cells from dividing by interfering with the machinery of cell division. But it also affects the ability of cells to repair from DNA damage. And that ability is why it might be a good thing to combine with radiation. And so that we don't know the answer yet, there are now several trials underway studying combining radiation directly with the Optune or tumor treating field device. So I've walked you through a whole bunch of information, and I'm going to summarize now. Radiation treatment is really a balance between tumor kill and normal tissue survival. We've developed a lot of technological advances in the field of radiation oncology that have allowed more options for patients. The therapy choices depend on the patient, the tumor, the toxicity, and of course, the severity of the disease. All modern radiation uses a three-dimensional approach of some kind, whether it's IMRT, VMAT, or proton therapy. We really are focused now on limiting radiation toxicity, and this can be done, for example, by avoiding the hippocampus or by giving a drug called memantine, or maybe both. And protons, which are actually a kind of particle therapy to cause its ionization, may be useful in preventing some of these toxicities when it's appropriate. And as I said, we're mounting evidence for when to use proton therapy. Now, by combining radiation with the latest drug therapies, we may be able to have the greatest improvement overall. I want to thank you very much for listening, and I think I'll take a look at the chat now and take questions.
Thank you very much, Dr. Sulman. So as a reminder, please use the chat function if you have questions on radiation therapy. We do have about 10 minutes left.
So let me look there's been a couple things already done. Someone has asked about laser interstitial thermotherapy, or LIT. And what LIT does is it puts catheters in the tumor and heats it up and destroys the tumor that way. Occasionally, laser interstitial thermotherapy is being used for the initial treatment of gliomas when they can't do surgery. It's also being used more commonly when tumors recur. And it's used also when brain metastases grow back. So LIT is commonly used for that. I want to apologize for all the lines on the screen. It wasn't me drawing them. I'm not sure where they came from. Let me address, someone's asked about the long-term effects of radiation, what happens 5 years and beyond. And I think there are two parts to that. There is always a risk of developing another kind of cancer from radiation. The risk is not, it's not something to ignore, but it's not very high risk either. And of course, giving radiation is a balancing act. If we don't treat the tumor now, that's far worse than the potential risk of a tumor of a different type many, many years down the road. There's also the cognitive impact of some types of radiation, and we haven't studied that enough. With modern radiotherapy techniques, we really don't know what is if any, is the impact of radiation 5 and 10 years down the road on memory and learning. And so that trial I showed you, NRG-BN005, will give us a lot of information on that topic. So someone's asked about the trial RTOG-9802 and whether the chemotherapy combination PCV is better to give than temozolomide. And this, for those that don't know, was a clinical trial that began back in 1998, but was not reported until 2015 in its final form. And it looked at lower grade gliomas, so grade 2 and perhaps grade 3 gliomas, though technically grade 2 gliomas, and found that it was better to give that PCV chemotherapy after radiation than to give radiation alone. The trial actually did not compare PCV directly with temozolomide. And so there actually has not been a trial to directly compare those two. And so this remains a discussion with the neuro-oncologist as to what is the best treatment for an individual. But we really don't have an answer whether for tumors where PCV was used in the clinical trials, whether that would be better than temozolomide. Let me see what the other...
There was another question. Is the 30-day radiation plus Temodar standard for recurrent GBM?
So recurrent GBM, there is no standard to give radiation a second time. There are several centers, many centers that do what we call re-irradiate. It would not be 30 days typically, though there can be cases where it would, but typically it's some shorter course of radiation, 10 to 15 days, sometimes 20. It depends on the specific circumstances. There is also a clinical trial that will hopefully have the result next year called RTOG-1205, which will look into whether giving the drug bevacizumab alone or bevacizumab with reirradiation is better for recurrent glioblastoma. And so we await that result as well. So there's a question that's a little bit personal, and I probably won't answer that in the specific case. But in general, and to discuss what you do for recurrent low grade, say grade 2 astrocytoma or oligodendroglioma, if no radiation has been given, it's very reasonable to give radiation. But removing tumor that you can see surgically, if it can be done safe, is always a good idea. Someone has asked whether we treat certain tumors differently in adults, say, than in children, and indeed we do. It turns out children can tolerate a lot of chemotherapy better than adults. So the primary differences are in the chemotherapy that's given, not so much the radiation. Though we do tend to try to reduce the radiation to children, so it's sort of the opposite. Adults can handle a lot more radiation than children. There's a question, does radiation given post-surgery keep working, possibly harming good brain tissue? Well, the effects of radiation do persist for months, but it's not a continuous harm. And again, hopefully the radiation is delivered in a way that minimizes dose to normal tissue. So another question is whether there's a recovery time for short-term memory issues after radiation. And one of the issues with that is there's a period after radiation where there's significant fatigue. And that fatigue is sometimes confused with the short-term memory loss. And the fatigue can last anywhere from 4 weeks to 3 or 4 months. After the fatigue is gone, any short-term memory loss that has occurred is likely to persist. And so it's sometimes hard to know what to distinguish the two until you get a few months out. And see, the last question I'm seeing now is, are there any FDA-approved PARP inhibitors? I think that's what was meant there. And PARP inhibitors are a relatively new class of drug called poly-ADP ribose DNA polymerase inhibitors. And these are drugs that inhibit an enzyme that's responsible for repairing DNA, including some of the damage to DNA that's done by temozolomide. So there's 2 trials that are looking at this on a large scale. One trial looked at a drug called veliparib in giving it with the temozolomide that's given after the chemotherapy and radiation combination, so what we call the adjuvant phase. And that trial has, again, finished enrolling patients, but it hasn't yet reported its result, and we're hoping that we'll have that next year. There's another trial that was actually conducted in Australia where they gave PARP inhibitor, again veliparib, with radiation and compared that to giving radiation with temozolomide, specifically in patients with unmethylated MGMT. So that's a marker for potential response to temozolomide. And unmethylated may not respond as well. So in that clinical trial, that one also is accrued, but we don't know the results. So there's a lot of good information that we're going to learn about in the next 12 months. Someone's asked, can radiation cause some hearing loss? Typically not in the way well, yes, radiation can cause hearing loss. Sometimes when a tumor is on the same side, one side of the brain, we often find it necessary to treat the tumor at the expense of some hearing loss on that side. We do that, but avoid giving any radiation to the hearing apparatus on the other side so that it's still possible to hear effectively. Let's see. Is there a shorter treatment time for GBM? Like 3 weeks, does age make a difference? So yes, there are different ways to treat, and there are times, some people do it for elderly patients, and some people do it for patients that have poor functioning going into radiation, where we treat for 3 or 4 weeks, but we give a little more radiation each day. And there was a clinical trial that we do know the result to that came out of Canada for patients that were elderly, though the definition of elderly was quite young, 65 and over. And I think all of us would agree that's not elderly. But in that trial, adding temozolomide to a shorter course of radiation was better than the shorter course of radiation alone. But it didn't do the comparison of whether the shorter course of radiation was just as good as the full course of radiation, the 6-week course. And there was
Are at time if you want to look at one more question. Otherwise, we'll say thank you very much.
And the person who'd like to contact me can reach out to the MBTS, and I'd be happy to talk to you, the person who wrote that.
Thank you so very much for your time, Dr. Salman. We really appreciate it.
My pleasure, and thank all of you for tuning in.
Thank you to everyone who joined us. And as a reminder, this webinar was recorded and we will be sharing it online in a few days. Thank you, everyone. Have a wonderful day.